question. But if there is none, is there anybody has any urgent question before we crack on? No? No. All right. So today is one of the two series of workshop, one we had last week, and today we'll be wrapping up for the year. Do join us next year. There will be a couple of sessions throughout the year, including a practical session. Today we'll be talking about clinical documentation, which I believe is the foundation of everything we do. As our bread and butter, it's impossible for us not to have a good grasp of clinical documentation as physiotherapists. So we'll be walking through out the day. What sort of things we'll be looking at throughout? We'll start by having some general concepts, understanding, conversation, definition, how you call it, just to lay the background of what's clinical education, what are the components of clinical documentation, the general principles surrounding clinical documentation, and some few terms that I think are important in clinical documentation. You will appreciate I will be biased towards the UK frameworks or conversation or context, but also I'm familiar with the Nigerian context and frameworks, and we will be making links to those bits. But I will also invite you to probably at some point share your context in terms of where you're practicing. Foundationally, and for me principally, I believe frameworks are foundations of process systems and processes. I'm not sure how much all of us are aware of frameworks that informed clinical documentation or frameworks that are used to support our clinical reasoning in clinical documentation. We will be drawing upon those frameworks to guide our conversation throughout the day. They will be the anchor of today's sessions, and we will be talking about them throughout the day. We will first look at what are they, and if you making reference to what you think they are in terms of how you applied it in your practice, and we'll look at then specific examples of how those frameworks are used in day-to-day clinical practice. We will be looking at the international best practices or globally accepted, I will say, frameworks as far as I am aware, the best globally accepted frameworks of clinical documentation worldwide. And then we see what is obtainable in your own practice as clinicians. And by all means, there is no right or wrong answers. We're just having a conversation, trying to figure out exactly what is the best way forward for you. Okay, so the whole conversation today is to inform the whole best way forward for you. We will then move on to just start to look at the future, well, current and the possible future. The world is changing. I think apart from we have the old age, we have the information age, we have the computer age in the 2000s when the computer blossomed. Now the world has moved or is moving at a very rapidly fast pace, especially within the last 5 years. Artificial intelligence, it's changing the landscape. I can clearly remember even in the Western countries, it was not a conversation 5 years ago, but now it's just that possibility. It's inevitable. It's inevitable. The people are embracing those artificial intelligence in their day-to-day practice, in their day-to-day activities. It's not. I know there are lots of conversation around it, ethics, legal frameworks, authenticity of it, all those things, but the reality is the world is moving in that direction, and it's just to inform us of what is happening and how we can join the train. Hopefully, and that's my hope, at the end of the day, it will be a personal conversation for each and everyone that has joined the training. It's not um, necessarily for me to share knowledge only or to have a conversation make a presentation, but it's for you to reflect, to think about what you're doing that is good, that you will probably continue to do it, just to reassure yourself, to think about what you are doing that probably is not good for your practice and for your patients, and then you want to stop doing it, and then to think about maybe new ideas that not only me have shared or bring to your attention today, but colleagues on this platform have added their voices and have shared their ideas and thoughts, and then you probably will take away going out for the day. So make it it's a personal journey today. Let's make our time here today worthwhile. Um, so when we talk about clinical documentation, I think all we are trying to say is that process of interaction, just to start with, lay the foundation. So that process of interaction between you and the patient, or not necessarily you, it's all the journey of the patient in the healthcare system. So everything single processes, but specifically in terms of the context of us as physio, is that interaction where we come across and have a conversation with the patient, and we try to document those interaction. And whatever it is that we do subsequently, we make reference to those documentation. So we will have the conversation, but it's only a conversation. It's the information that we captured in the documentation in that interaction that makes sense going forward, because our memory is limited in a way. So how we capture that information is important. How we document that information is important, not only for the patient care and journey or improvement in his outcome, but also for non-clinical purposes that informs the health services. And it's important that we have a structure, which I believe most of us do, but just to highlight, it's important that when we are capturing that information, we have a structure, and the content of that information we are capturing reflects best practices. And we will be looking at those best practices that we are talking about. And we talked about it should have a structure. We will be talking about what the structure are. And I believe all of us probably have been using one structure or the other. Absolutely, I believe so. Or just to reflect and see if we can make it better, especially in the context of digitalization. And the purpose of those conversation, capturing those conversation, the purpose of why we gather those information is for optimization of patient care. We reflect on what we are doing as healthcare professionals. We look at, oh, this is the background of what the person have said. This is what's my next plan, and then this is whether it's working or not. So it's looking at the patient journey, making reflecting back and see whether your treatment or intervention is working, or how you can tweak it to improve the patient care. But also it is it's the communication document for between healthcare professionals. I believe we cannot always be around to tell the next healthcare professional. I wouldn't have imagined a world where we will only say, oh, I have seen this patient, this is what it is, and everything. And you passed on all the information that you have on this patient to the next person. It's not going to make sense. And there are a lot of research about how information, especially verbal communication, mixed in conversation. But documenting it, writing it down, putting it, enables the next person who will continue in the patient care to be able to pick it up efficiently and then apply it in their own practice. And foundationally, if your notes cannot be taken by another healthcare professional, I think we need to review it. If your note cannot speak for itself, even without you being there, then you need to review it, because it's a system that needs to carry it on. So whatever you write in a patient's note, is important you understand that your colleagues will come and pick up those notes, physiotherapy colleagues as well as non-physiotherapy colleagues, to apply it to patient care. And we expect the same. I didn't know. I think sometimes I have been in situation, well, of course, not that necessarily that I myself I am the best note taker. Of course, everybody notes have its own variations of flavor, but I know that I have been in a situation where I had to think what is that what is the note speaking about in terms of the patient, and I have to go back and do a quick reassessment because I couldn't figure out from the note what to do next. And possibly also my colleagues have also reached out to me to say, oh, what did I write here? Or they couldn't make sense of my note. So it's important that our notes speak for itself and our colleagues can take over from it. The notes also are used for audit and research. And if it is not a practice in your setting, I will encourage you to consider the notes are using notes for audit and research. Research can be a big thing, but you can do a quick audit. For example, I have been in a setting where so one of the audits they do, or just to improve the standardization of note taking, is they noticed that people are using a lot of abbreviations. Now, there is nothing wrong in doing abbreviations. However, if the abbreviation doesn't speak on the information you are trying to communicate, then it has defeats its purpose. So people used a lot of abbreviations and all is audit. So one of the senior members of staff just reviewed certain pieces of notes from different people and then make a recommendations. And the trusts or the hospital or the service decides that to avoid using abbreviations, just to use plain language so that people can be able to understand what you're saying without scratching their head. So this is just because one of the purpose of notes, but also it can be used for research, to just retrospective research where people will look at it, look at the data, see the trend in terms of patient outcome and see what they can do. In certain claims, the last one, which is the medical legal evidence, is very strong. So our notes are legal documents that are used in courts, and we will be looking at that throughout the day. So whenever we're writing stuff on paper or on the computer, we it's like it's a document that can be admitted in court. So it's important that we write it legibly, the clear structure, and the content reflect exactly what has taken place. So I guess there is a popular saying that says, if it's not documented, it didn't happen. I didn't know how many people have reflected or think about this, but the reality is there is no amount of conversation that you can say. Let's say if a patient, you finished an interaction with a patient and 1 month ago, 2 months ago, and then a patient come and challenged whatever has happened or trying to find their information. The reality is, A, even if you can remember, it will be very sketchy. But B, by global best practices, it is not, if they can't find it on documentation, it absolutely did not happen. And it's a crucial principle in the Western country where sometimes your note taking is even a greater priority than every other thing, because a proper healthcare is important, is essential for providing the events, proper documentation rather. It's important in providing the events that occurred during that interaction with patient. And that will be the basis of conversation if there is any legal complaint. But it's not about legality of it, but it's ensuring that accountability in terms of what you've done for the patient or not, continuity of care, legal compliance, and effective decision making. it's not written, like I said, it didn't happen because patient can easily dispute what you've written or even forgotten. Sometimes it's not that the patients are mischievous, but just they forgot what you've said. And as a clinician, it will make you legally vulnerable if you do not document exactly the events that happen. And this can lead to a risk of a lot of malpractices claims. It's a big thing as a clinician, and sometimes poor communication, like we talked about, among the healthcare team, and it won't speak well in your favor as a clinician in terms of professional standing. So one of the things I want us to think going forward, it's documentation. It's an important communication document between us and the patient, and I think we owe it a responsibility as we called ourselves professionals. So professionalism comes with accountability that we have to write on with our interactions with the patient. Even if the legality doesn't comes in play in terms of the context at which you practice, whereby you feel, which I think you are legally bound, but the application might not be effective. But there are countries where you are legally bound and it's statutory, especially in the Western countries. So what is the general principles for note taking? It's the accuracy and factuality of what you are putting in. The accuracy and factuality, all entries must be true. So when you're writing the notes, it has to be reflect exactly the accurate statement of fact, what you've written, or your clinical judgment at that time. Now, it's not a problem of whether your clinical judgment is wrong, because you have the scope of practice to make those decisions. But it's just explaining the rationale on how you arrived at that decision within your note. And it's not about your opinions and assumptions. I will strongly encourage you avoid putting in your opinion and assumptions, which I believe most of us probably are doing as well in note taking. It's about statement of facts and clinical decision making based on your training. And if you feel you want to put patient quotes in terms of what they said and to reflect, it's encouraged, like in normal issue, to put it in quote, or maybe they said the patient said. But if you want to put their quotation, you put it in quote. Clear, concise notes. If it's typing, it's easy. Typing, it's all legible. But if you're using high written note, I think it's consider how clear it is, how legible it is, so that other healthcare professionals can be able to take that bit. The next thing is the completeness of note taking. All note taking should contain all the relevant information that are necessary for the patient care. And everything we usually take in our practice. But it's important, especially at different time points. For example, if you're doing an initial assessment, I believe there are information that you need to capture as sufficiently as possible so that even if you do not continue the care of the patient, uh, another person coming in to carry it on will be able to take over and apply that and continue from where you stopped. But also irrelevant patient information should be excluded. Should be excluded. So when you're writing note, think of it this way, that you will not be always present. The next one is the timeliness. You will not be always present and anything can happen. So if you're not around, what will the other person, the patient care has to continue. What will the other person rely on to do? So don't write notes for your own consumption or for your own understanding. Write notes for the wider team or wider understanding of the team. The timeliness of note taking is highlighting the contemporaneous nature of documentation, whereby notes should be completed during or as soon as possible after the patient encounter. While the information and clinical reason are sort of fresh in your mind, you can figure out, oh, this is what is it, this is what I've done, this is what I've applied. Before the busyness of life takes over. In other climes, and I did not know in Nigeria, and I think you guys are better positioned, like I said, to advise. In other climes, there are time frames where a clinician must complete their notes. Some usually said within 48 hour maximum. Now the time frame is maximum. Some will say within 24 hours, and certain practices before you leave the setting, you must complete your note. So once you finish seeing the patient, you write the note and then you continue. And it makes sense. It makes sense. Imagine that, and some will say immediately after the patient. So after each patient, you write the note, because it might be that after you just finished seeing the patient, something might just take off your mind, or you'll be called into a different place, or anything really, because we are not in control of the other external factors around ourselves. And then somebody comes and want to carry it on with the care of that patient. Without your note, they won't be able to understand what has been done and what's to continue. So the contemporaneous nature of documentation is absolutely important. And like I said, once that time, as a professional, if you breached those sort of timeline of completion of notes, it's something that your professionalism can be called into questions in certain places. And I want you to probably reflect and start to think of note taking, not something casual, but not something that will affect the patient journey, because I believe we are there for the patients and sort of interested in the patient journey. And one of the things that will improve the journey of the patient is not only the notes, but also the time frame at which we complete the note. Despite our business, how busy we are, it's better we complete the note and everything for a patient than to consider the quantity of the patients we see. The specificity of the next point is the specificity of the note taking. Most of us are using outcome measures, I believe. So that's what it's referring to, whereby we use the objective measurable data to track patients' progress and determine its efficacy. But also the note reflects the thought processes. So it's very specific in terms of justifying our decision of the interventions, using terminologies that are very clear rather than broad terminology, and where possible, reflect the collaboration with the patient, including their progress. So if possible, if you capture their progress in measurable data, that would be brilliant. So if you are using time up and go test, maybe from 15 seconds to the patient reduces to 12 seconds. And informed consent, we document whether the patient has given us the permission for the treatment and things like that. The last bit of it is the compliance side. The compliance side. So there are lots of legality and ethical expectations for a physiotherapist when you're working in the healthcare setting. And those legality and expectations, they are statutory, means they are enforceable, means that you can be called into question. It can make you to be struck off the register. In Nigeria, MRTB, as we all know, is the statutory regulator, and the NSP is sort of the association or the body in sort of influencing those conversation. But there are also broader health laws that we are expected to abide with it. But globally, especially in the whole European context, and I believe in the other spheres of the world, there are general compliance issue on how we handle patient data and confidentiality. Patient information, the conversation they had with us, is confidential. And by confidentiality includes sharing those information only with those people that are absolutely relevant, securing those information. Not so once you finish documenting that, how do you store those information? Even if it is in paper or digital form, I think it's how do you store this information? If you have a record system, paper record system, it's about how do you store those records information, and we can influence that in our practice. The places where those paper documentation are kept should be out of bound to people, but also before you store them, once you finish the documentation on your table, it's not okay for you to just leave it, patient documentation open, and then the next person coming in, they can see exactly what has been done, or you just family, friends coming in, and then they can see what they've been done. So confidentiality, how do you secure that information? And access and disclosure should only be on the need to know basis. Usually there are legal and ethical guidelines surrounding that, but in your practice, if you don't have one or if you're not aware of one, I think the broad expectations from us as professionals is the access and disclosure. It's not okay for somebody to just zoom in and say, oh, what did this person come to do, or what's wrong with this person? Or when we go out having a conversation and just chatting about patient conditions just to show that we have seen XYZ. And that is why maybe it gives confidence to certain people, especially people that travel out to the West. You will imagine that there are lots of big men or politicians that tends to travel out to the West, but rarely speaking, do you hear about their information data, even though sometimes it's accessible, because once as a professional, if those information are out and they've been investigated, you can be sanctioned if you are not obliged to share those information. You can be struck off. You can even lose your job. I know there are instances where people try to log in, have a look at people's data, and then it has a legal implication. So I think we can apply it in your own context. Start to think of it's it the confidentiality side in terms of the patient note. I think it gives patient confidence that whatever they share with you will be respected, their privacy will be respected, and they feel safe. And because if patients don't share those information also with you, on the other hand, so that trust building will affect your ability to make your own decision. So compliance, yes, and accountability and identification of information and possibly use of standardized format. So general principle, accuracy, completeness, timeliness, specificity, and compliance. Yes, we are doing that, but if there are areas you feel you could improve, I think it's sort of good point for us to reflect on what we're doing. Now, the context, I think we've talked about this briefly in our previous slides. So there are ethical and legal contexts whereby, as per legal requirements, legal claims purely relied on documentation. In fact, there are what we call medical legal experts. So people purely who have experience in these bits, and they will come and have a look at it, especially when there is a legal a patient sued service, or a patient sued therapist. The main points that will be looked into is your note taking. The main point that will be looked into is your note taking. And remember, patients, well, I think it's applicable also in Nigeria, but I'm not sure how much patients are aware, because I've listened to it, is patients can request to see everything about themselves. Everything you are writing about the patient, they can decide to have their record under the Freedom of Information Act to see everything you've written about them. So think of whatever you're writing, patient can have access to it. And certainly in Nigeria, physiotherapists are accountable under those health laws and professional regulations. There is also the ethical obligations, where we talked about the accountability, and failure to document can be considered as negligence. I believe it's the ethical documentation is also doing the right thing for the patient as well as for the profession as a whole, because these are things that will put the profession in good light. People will have confidence in, oh, physiotherapists are sort of good note takers. If I went and speak to them, my confidentiality is protected. It's the same thing as you hear about patient or client confidentiality, where lawyers tends to put out waive that to people a lot, and they don't necessarily share information, and that gives trust to patient to their clients. I would say, where you can imagine even a criminal will be so comfortable to go and speak with their lawyers because they feel um, there is that privacy, there is that confidentiality, their information will be respected. So it's that trust building, I think, from us that we need to also consider, apart from the legal implications where we are obliged, but that trust building in our patients. And if you are working in private practice, I would say this is a very good opportunity if you build that trust with your patient in terms of a patient will trust you and more clients, and then they will sort of speak well of you. And then the professional context, it's about the competency through clear documentation and assessment, reflecting our clinical reasoning, which in Nigeria, the MRTB sets poor documentation damage the credibility not only of the person, but also the professional reputation. And the clinical context, which I think that's the most or biggest parts that we tend to do or write, it's the continuity of care, um, not only within physio, but across the multidisciplinary. And like I've mentioned, incomplete notes can lead to poor management and will affect patient outcome. It also, it's safety. So apart from patient care, it's the safety side of things. Um, Avoiding duplications, omissions of treatments is the safety side of things. Certainly, the hospital management would like to claim their money. I'm not sure how big is insurance. Well, in Nigeria, probably less, but here, especially both government and private practice, insurance is a big thing. And insurance claims heavily relies on the professional documentation of the therapist. So institutions really required a proper documentation because that's what they use to claim back their, if they have a private patient or insured patient on their list. And any misdocumentation can affect their financial, it makes them to lose their finances. But also as an institution, there is an obligation. Sometimes it's not down to you as a clinician, but as an institution, there is an obligation and they can face some regulatory penalties. Maybe something the MRTB should start thinking. But anyway, that is, as an institution in certain world or climes, there is that regulatory expectations. And the educational sites, it can be used as a training tools, Maybe think of it this way. When you are having, for those that are maybe HODs or intern coordinators or unit department, one of the activities you can do for your students that or interns that comes is try to, it can you be used to inform their, to learn about clinical reasoning, seeing a proper documentation from any colleagues within, experienced colleagues. You can have a conversation with them, seeing a clinical reasoning. Certainly when I started practice, and when I go to new places, especially when I migrated, or Japan now as it's called, from Nigeria to here to UK, it's because sometimes you want to understand how the note taking are done and then the thought processes. I read about other colleagues' notes, colleagues that I know they usually write good notes. I sit down and go through their notes, and you can see how it sort of shaped. You can see the journey. It's like a storytelling from the subjective going to the objective, and then making the analysis of findings based on the subjective and objective, and coming up with a treatment plan. So yes, even not student and intern, as a clinician, we can learn from each other, going through it, just to learn about the how other colleagues are doing things and how we can best inform our own practice. It can be used also in terms of quality improvement, evidence-based practice, policy documentation, and there are proper opportunities for learning and research. In the UK, for example, there is what they call, so there is a national data collection processes or system. In stroke rehabilitation, for example, they are expected to report how much time they spent with the patient. So it's a snap data. So basically, it's the data that has been collected all over the country from clinicians about how much time they spent with their patient. It's just to give an indication, understanding on whether they are. So there is usually a nice national guidelines of the time is expected for a clinician to spend, and then the reality, just to see what is the gap and how to fill the gap, just to use that data for policy development and quality improvement. So a lot. But I've spoken for roughly about an hour, and I want us to have a quick chat, really, about first is if there is any question on everything that I've spoken in the morning, it's still morning, on the note-taking clinical documentation, but specifically is starting with number one, informed consent. What does it mean? What do people understand by the word informed consent and its implication in your practice? Its implication in your practice. What do people understand by informed consent in the context of your note-taking or clinical documentation? By all means, please unmute yourself. It's good to hear your voice, to know that people are still listening, or you can put in information on the chat box. What do people understand by informed consent? Don't worry, there is no right
Good
or
morning,
wrong.
sir.
Yeah, good morning, ma'am.
Yeah, it's like taking consent, like permission from someone to carry out like a research to get some information from the person.
Okay. Thank you, Jennifer. You said to carry out a research to get information of the person. Is it only research?
To get no, it's not only research, maybe to even perform like a procedure on a patient.
Okay. And how does it apply to you as a therapist, physiotherapist? Think of it in your clinical documentation practice. How does it operationalize? If you can make it simple. Thank you for your contribution. Anybody? So thank you, Jennifer. What do other people think about informed consent?
Hello.
Yeah, good morning.
Yeah, good morning.
Yeah,
What I think about informed consent is ensuring that you get the patient carried along in your procedure so
okay.
that he's aware of what you will do. And one of the implications for that is that it has a medical legal implication and it
Yep.
can be used as evidence.
Thank you, Chairman. Yep.
Yeah,
And
thanks.
thank you. And what do people still understand informed consent? So key points that was highlighted by Kelly is the implications of not taking informed consent, using it as medical legal evidence. Well, he mentioned about carrying people along, so carrying your patient along. How do you do that? How do you do that? That would be my question. How do you carry the patient along? So talk me through it. Yes, Kelly or anybody.
Okay, yeah. One of the things you do is that you must document it, you must write it down. If it's not written, it has not been done. And it is okay that you get the patient to understand you and to give you a feedback and you document. I think that's just what I would say.
Okay, thank you.
Good morning.
Yes, good
And
morning. Yes, good morning.
I think informed consent is just like a patient-centered care. Patients
Okay.
has to be involved because patient can, if maybe you want to carry a procedure, and
Okay.
patient may likely not like it, and he has
Mm,
the right to reject it.
yes,
And if you have an alternative way of doing it,
exactly.
you
Yeah.
can do it other way. So
Mm,
informed consent is just a form of patient-centered care. Patients
mm,
are involved in their management.
mm.
Thank
Thank
you.
you. Yeah. I think that's a good point. So now, Rab, you have already started adding the second point, patient-centered care and informed consent. That's good. But patient-centered care probably goes broader, which is excellent combination. They are linked, but it goes broader than informed consent. But anybody, one more point before I proceed. What do people understand by informed consent? And then you can also talk about patient-centered care since Rab, you have already started talking about it. So what do people understand by informed? Anybody wants to add? Thank you for excellent contribution so far.
Good morning, sir.
Yes, good morning.
Yes, sir.
So what I understand by informed consent is that maybe you want to carry out a particular exercise on a patient. So you explained the procedure, whatever you are doing, what you want the patient to do, and also the result that is expected from this particular exercise. Then the patient now agrees for you to carry on with the exercise, whatever procedure you want to carry on. And so that is what is informed consent. This is what you want to do. The patient agrees that you carry on. I understand by informed consent.
Okay, stay
Thank
with
you.
me, Favor, before you go. So thank you. So the explanation that you've given, it's the information. So informed consent means the patient is giving his permission, but before he gives his permission, that's what Favor has explained. He needs to be aware of what he is giving his permission. So that's a good example, Favor. So patient gives his permission, but before he gives his permission, he understands why he's given his permission. So it's not okay for patient to give his permission, but you as a clinician has to explain to the patient why he is giving his permission. I think Rabiu Abdul Hamid has put a clear has put a chart on the chat box. But Favor, you mentioned something. You said when you want to carry out a particular exercise, is it only when you want to carry out a particular exercise that you get the informed consent, or it's just an example you are given?
It's just an example. Like I said, exercise or any procedure that you want to carry with the patient, it's not only exercise.
Okay. Thank you so
Yes, sir.
much.
You're welcome.
Yeah. So, well, that's good. Excellent. I think from the conversation, it enriched. So, informed consent, everything what people have said is true. But we have, so informed consent is the, right from the start, operationalizing in your practice. The first thing you will do is right from the start, your patient entered your clinic. After the introduction and initial hello, hi, you have to gain consent from the patient. And it's not only saying that, are you happy for me to carry it on to continue the session, but also explaining to the person. For example, hi, my name is Timothy. I'm a physiotherapist. I'm here today to sort of do some physiotherapy assessment as well as treatment. Okay, I will start by having a conversation. Now, that conversation is around subjective. I will start by having a conversation. And then from there, I will come over and do some assessments on you. I will probably use my hands. Is that okay? And the patient would say yes. Now, if the patient said yes, that is a verbal consent gained. By patient saying yes, I would document it like Kelly mentioned, that the patient have said yes. And because we are professionals, it is expected that even if we are the only people let's say you are the only therapist patient, I will not document yes if the patient has not said yes, because the patient has not given his permission. That's that professional duty or expectation. So I wouldn't document what the patient has not done. Tomorrow, if the patient comes back and said, oh, why did I, or he challenges that bit, my notes, once I've gained that permission and my notes have clear understanding why I applied certain treatments, I am covered. Okay. However, if the patient has not said yes, even if I do something that is good for the patient, I am not covered. That's one. When I start the conversation, so like Favor mentioned, informed consent has to be continuous, because when I come to do some manipulation, after maybe I'm doing this for my subjective conversation and I'm trying to do some objective assessment, when I come back up, I will still explain to the patient a bit of, oh, you may feel a bit of pain. You may feel a bit of discomfort, but it shouldn't be painful. Or you may initially feel a bit of pain, but this pain should go away. Okay. At any point in time when you feel uncomfortable, please do let me know. If it's too much, I will stop. And then I will carry it on. And when I'm asking the patient to do a treatment, for example, the exercise Favor mentioned, I will also explain to the patient, or I will, and I will probably you will be standing on one leg. For example, if you are doing a balance exercise, is that okay? The patient will say yes. Now we can run rapid around the conversation. It doesn't have to be a monotonous exercises. Most of us probably are doing it. It's just a smooth process. But for the patient to say yes, the patient has to understand, and I think that's the message Abdul Hamid have put in, and everybody has spoken. And for them to understand, they have to have the cognitive ability to understand. How do we assess the cognitive ability, or how do we know that the patient have the cognitive ability to understand what we are saying and saying yes? Because if they said yes and they don't understand what we are saying, is that a consent? That's my question. If they said yes and they just nod their head and said yes, and they don't understand what we are saying, is that a consent, or is that a way to go around it? Anybody?
If they respond yes, but they don't understand what you are asking, it's not a concept. And there's a way to go around it. Like for those who are speech impaired now, you need to get people to interpret somehow, like an intermediary. And for people who are deaf, you just need to know how to communicate to those who have impairment in that regard. And then also where the patient's consciousness is not certified, where the patient is not conscious, I think we can make use of a patient relative or a caregiver, somebody that can give consent on behalf of the patient.
Thank you, Kelly. But I think, Kelly, you've touched on two different points and not my question, which is good. So first point you touched about is non-verbal consent. So Kelly has highlighted what we called non-verbal consent. So when I said yes, I am giving a verbal consent. There are patients that cannot open their mouth and said yes, but they can also understand exactly what we are saying, and they will be able to give us consent without opening their mouth and said yes. Those are the ones that Kelly mentioned about speech impaired. And how they do that, usually it depends on the care settings. Sometimes the speech and language therapist, which I know it's communication strategies with them, and that communication strategies might involve them nodding their head, raising their hand, thumb up, or they will try to look. So there are patients that cannot raise their head, thumbs up. All they will do is you will bring a sheet of paper and they will blink their eyes. And that is consent.
But that is for if they have the capacity. So if they have the cognitive ability. So there are non-verbal consents that we can still get from patient using other non-verbal communication, blinking the eyes. Can you blink your eyes if you understand what I'm saying? Raising their hand or shaking their head if they don't want the consent. So these are non-verbal consent. Now, the second bit is the interpretation intermediary that was highlighted is if there are language barriers. If we are communicating to our patient, if we say patient-centered care, and that's what I think Gabi started to mention, and we are drifting towards that, then we have to wrap our conversation around the patient. I believe there are several times patient comes to our clinic and we don't understand what they are saying. They don't understand what we are saying. How do we communicate to them? So that's why you have an interpreter that helps translate or communicate what you are saying to the patient. And believe you me, there are lots of interpreters. In fact, from different languages, including Hausa language. Here, people employ professional interpreters. If in Nigeria, I would expect that there are no professional interpreters. Well, there are professional interpreters. I mean, it's a luxury to have one. You can use the patient relative. And even here, people use patient relatives, but usually there are also professional interpreters where you interpret, they interpret in between. But coming back to my question, so thank you. Kelly mentioned about nonverbal communication, language barriers, how we can go around it. But coming back to a patient, if a patient doesn't have the cognitive ability to understand what you're saying, what does it mean really, and how do you go about it? I think Chairman Chair has started to highlight a bit of consciousness and things, but can either tell you anybody really expand on how do you go about it?
Good morning, sir.
Yeah, good morning.
So actually, if the patient is not having cognitive ability to understand, as the case may be like the one that is not conscious, we can explain to the patient relative so that we can take the consent exactly the way surgeons are doing when they are doing the surgery.
Yeah.
The relatives may give us the consent that we can do our own intervention. Thank you, sir.
Okay. Thank you, Dr. Umar Abdul Hamid. So yes, we can take the relatives. Anybody wants to add on that before we move on? No, I think, yes, carry on. Yes.
Yes, sir. I also think we can quickly do like a brief cognitive assessment using like different outcome measures, like the 6-item cognitive skill, just briefly, just to really ascertain if the person does have a cognitive issue or is just an interpretation barrier. Thanks, sir.
Excellent. Thank you. I think both you and the last speaker have spoken excellent, or everybody, but you have spoken on different aspects, which answers my last question. Now, there is that consciousness where the patient is unconscious, not necessarily they have lost their ability, because at that point in time, they can't give consent. And that's where we ask the patient relative, absolutely fine. In terms of people acting in best interest, well, we ask the relatives. And we are fortunate in Nigeria that we always have relatives around. We have people that will always be around. In other climes, usually there is what we call power of attorney. So there is usually a legal document in certain countries where, as a patient or a person, you have given the responsibility of your health care to a nominated person. And when you are unconscious. Let's start from when you are unconscious, like the example that was given by Dr. Abdul Hamid. That is the person that has that legal power of attorney for health and care that is now entitled to act in your best interest, and on the basis that the person understands your interest and preferences. The whole idea is about the interests and preferences of the patient, and the decision that will be made or suggested to be made will be made in the best interest of the patient. And yes, the person can act. Specifically, I know in Nigeria, probably we relatives will suffice, but if you happen to find yourself in other climes, usually there will be a legal document most of the times that will act on that in their circumstances. And yes, if there is none, the relatives will be able to consent. There is also on the other part whereby the patient is conscious, but they don't have the cognitive ability. And that is where Adi feel goodness is trying to mention. Usually there is what we called, you assess their cognitive ability. I didn't know how much we do in our context in Nigeria, but I believe we do some of it. In certain countries, there is a law or a framework or a clear guideline on how you assess an individual mental capacity. And it's under what they called in UK, the Mental Capacity Act. And you can check, I think it's 2005 or so. So it's recent, Mental Capacity Act. Now, the mental capacity is, you always assume patient has capacity until proven otherwise. And for it to be proven otherwise, it has to be assessed, okay? Assessed in terms of the ability to make decision. It's not whether they are conscious or not. Yes, they are conscious, but the ability to make decisions in life decision and everything. And if they lose that capacity or they don't have the capacity, before they lose that capacity, if they have somebody who already they have given that power of attorney for health and social care, that person will act in their best interest in all their healthcare decision, even though they are conscious, even though they can speak. But of course, you always speak with the patient, and most of the times it's around the interest preferences of the patient. And then there is that best interest decision whereby a decision will be made. If you don't have the capacity, you don't have a power of attorney, you don't have a relative, which it might be in our context very unheard of, but there are situations where you don't have a relative, you don't have the capacity, and then you are just in the health system. A best interest decision can be taken based on the information that people know about you in terms of to provide care for you and what is available on your record. And informed consent can be also, example is best, usually patient can make an express wish. For example, CPR, we all know popular CPR. A patient can already make an express their preferences whereby they don't want to have CPR or resuscitation if they are in cardiac arrest or about to die. And that has to be respected. So it's already documented. And in that case, whenever the patient is having cardiac arrest, you as a healthcare professional, you are professionally bound not to carry out that cardiac procedure or that chest compression. So in summary, and thank you so much for the conversation. In summary, informed consent is the process. So it's a process by which the patient or your patient or a patient voluntarily agrees to a proposed procedure, intervention, treatment, assessment after being fully informed about the nature of the treatment or the nature of the process, the benefits of it, the risks and possible side effects, and what are the alternatives. I think Rabi mentioned about alternatives, including doing nothing, and what are the likely outcome. Patients are allowed to make poor judgment if they have capacity. So in physiotherapy, in us, before we start any assessment, any treatment, the recommendation is explain to the patient in understandable language. That's what I think Chairman mentioned about communication, understandable language. There is no point of us speaking good grammar and English and feel like our patient has to understand grammar and English. I think that's not professional view. While it's good that we're fortunate we understand grammar and English, but if a patient can't understand Ibibio, Efik, Fulfulde, all those languages, or Tangale, all those languages, then we are not delivering the service. Ensure the patient has the capacity to give, obtain a verbal or written consent depending on the intervention, or even non-verbal consent like I mentioned, and document it in your clinical notes. I think it's always the first thing that you will find in all clinical notes in other clients. The first thing that you will see, the first thing, it's that consent. Now, this protects the patient autonomy, the rights of the patient, and sort of meets the legal and ethical standards. And then secondly, we've started talking about patient-centered care. Now, informed consent, it's that part of that patient-centered care whereby we are placing the patient right at the center or heart of all decisions and actions that we are making. It involves the process where we are respecting the values, preferences, and the needs of the patient. And sometimes in physiotherapy, you can say it's about how we tailor the treatment so it's not only the informed consent, it's the patient-centered care goes beyond that. It is a process where the patient, in our subjective conversation, the patient will express their preferences, their wishes to us. For example, they will say, oh, I have grandchildren and I would love to play with them. Oh, I have a farm in Potiki and I want to go to my farm in my village. Something like that. And your treatment is to plan it around that patient goals. For example, being able to play with your grandchildren, being able to return to your farming, being able to improve your walking. So you are not working to improve strength of a patient. No, you have to improve strength, or you have to reduce pain, but you are working to make it relevant to the patient. And we will talk about the frameworks and how to do that. So it's you engaging the patient or having what we call a shared decision making. I guess it's a shared decision making. Yes, you are the expert, but it's not a paternalistic relationship whereby you sit at the top and you are making those decisions for the patient. You tell the patient, bend, flex, or stand up, sit down. No, it's a relationship between you and the patient, shared decision making, respecting the patient value. You are there to deliver the service. And that is professionalism. That is what is considered professionalism. And it has big impact. Considering every factors, I will look at those frameworks that how you can consider those factors. And you communicate very clearly and empathetic about the patient situation. And then the last point, which the third one on my PowerPoint, is the roles and responsibility in the concept of note writing and delegation. Maybe I will explain this because it might sound a bit vague. What I mean is that we've talked about, as a professional, we have a responsibility from everything I've talked earlier on to write our note. We absolutely are responsible to write our note accurately, in a timely and professionally, of anything we do about the patient, because they have legal implication for continuity of care. But that doesn't stop that. When we are delegating those responsibilities that falls within our jurisdiction, when we are asking those rehab assistants or those porters, those people that support us in enhancing the patient care, or support workers, we are assigning tasks. Or students, because students are not they have not get the qualification or registration, we are asking students, we are still retaining the accountability. So it's not enough for you to tell somebody to do things for your patient. We still retain the accountability for the patient safety and the quality of care that is being provided. So what it means is that when you delegate somebody to do it, make sure you are delegating it in the context of their competency, not asking them to do things beyond the context of their competency. Because if anything goes wrong, whilst they are implementing your instructions, you are accountable for the care of the patient. So context of their competency. Ensuring all the things, so only delegate tasks within the competence of whoever you are doing. If it's a student, within the task, if it's a porter, within their task. And it's not only within the context of their competency. Think of it this way: if you ask them to do things and they are not clear on what to do, even though it's within their competency, they might not be able to implement it very well. So it's also our responsibility to delegate this, to give that clear instructions. And if we are putting it under also, sometimes it might be a supervision. It might still happening probably in Nigeria or other clients, but when it comes to documentation, sometimes they will write their names, or sometimes when they write their documentation, some write their documentation, some don't, they report back to you, but you can double sign whatever they've done, they've documented. If you're in your context, if clinical professionals, if support workers are allowed to write a documentation, sometimes there is expectation, certainly for the students on placements or students that are common shadowing. If they write the documentation, we expect the professional, you, the qualified physiotherapist, to double sign, double check that note to make sure that it reflects actually what has happened and you're happy for it to go as a medical evidence document for the patient. So yes, thank you so much. Is there any question before we move on to the next part of today's training? Any sort of a burning question so far? Nope. All right. Well, models and documentation. I think I probably will have one for you very soon. So models of documentation or frameworks. Models are conceptual frameworks, or so that what we call theoretical frameworks. So they are just theoretical conceptualization of how things, or theoretical conceptualization of system and processes of how things should flow. And those models or frameworks, they help explain the pathway you follow, or sort of give you a process where you can organize information or apply it or discuss conversation. And they are applied, theoretical frameworks are applied, broadly speaking, not only in healthcare, in most systems and processes. But in healthcare, they help us in sort of organizing those information, the documentation we do. They help us in our clinical reasoning. They help us in our conversation with professionals. And it helps us communicate globally, not only in our local context, but when you are saying this is this, this is this, this is this, everywhere in the world, people know what you are referring to. My question is, do you have any ideas of, or people that have ideas of theoretical frameworks or models underlying documentation generally, or patient assessment generally? What are those sort of frameworks that you are aware of or that you are using to inform your practice as a clinician? What are those frameworks or ideas that you are using to inform your practice as a clinician? And please, you can unmute yourself or put it in the chat box. What are people's thoughts or frameworks and models, and what are the people using in their practice? Any idea? Don't worry, there's no right or wrong answer. Anybody has any idea, any examples, anything? Okay. I would so well, there are two I will probably process. So have we heard of this? Two sort of, these are what I'm referring to, or when I talk framework or model. Have we heard of biomedical model and biopsychosocial model or frameworks? You just put a chat on the chat box if it is new to you, please put it new. If it is you've heard of it, just put a chat box yes in the chat. I just want to understand how much information I can share or how much depth of information I can go into. So can you please put in the chat box if you are sort of aware of this, just put yes. If it is new, just put new, because I don't want to go in detail and repeat information that you are aware of, but at the same time, it is the foundation of our conversation today. If it is new, then I need to make sure I explain myself very well, even if it is the only thing we'll talk about today, because I believe this can transform your practice as a clinician. Okay, so I can see new. I'm still waiting for more responses. So 4 people have put in. I'm still waiting for more. And I will say, please add your comment. While you are adding your comment, I know we've been talking for 1 hour, 30 minutes-ish or so. I will quickly go for what I called a screen break, just to take our eyes off the screen. Okay, it's not new. Okay, brilliant. So Chairman will help me in the conversation. A few people said new. Okay. All right. So can we take a quick 15 minutes break? We're going to come back by 10:45, but please, I want more responses so that I can understand I want to read the room. Okay, AE is not new. So keep on putting your responses. I'll keep reading them, but let's go for a quick 15 minutes break, and then we come back by 10:45. So it's break time. Grab a drink, coffee and everything. We come back at 10:45. Okay. All right. See you by 10:45 then. But please keep the conversation. If you can't put as much information, put it in this bit. Whether it's new or not new. So far, 2.5 people, if I would say it, not new. I want more responses, please. Thank you. See you by 10:45.
All right. Welcome back. I still have my question on the board. I hope you have a quick stretch, rest, drink. So welcome back. I still have my question on the board. A couple of people have already responded. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So before we go on a break, we are looking at models of practice that underlines your assessment generally, or informs how you go about assessing patient and subsequently documenting it. So my question for everyone is that looking at those models, is it new to you? If it's new, just type new. Or is it something that is not new to you? If it's not new to you, just say yes, you are aware of it. Just type yes, or just put it not new. And a couple of people have put in. So if you're still on the call, can you put in your responses? If you've not, but those that have put in their responses, thank you. And I think that for those that it's not new, the question is, are you using it in your service, or what model do you think you are using it in your service? And we'll come back to, we'll look at those models as we go along, but what models do you think you are using it in your service, or how practicable it is you are using it in your service? From the chat, I can see it's only one person, or one and two people. Yeah, 2.5% that mentioned yes. So AE mentioned using it in their service. Adodoku mentioned it, but not in the context of training. And then Kelly mentioned it is not new. So among those people, 3 persons that mentioned about not new entirely. What models, if you do you think how you are using it in your service, and you can go and expand on how you are using it in your service? If they are back on break, and if they're happy to unmute their mic and share their thoughts. Among A, Kelly, and possibly Adodoku. Okay. Okay. Mariam mentioned not new. Mariam, also, do you want to share, expand on, or you use? Okay, you use Biopsychosocial. Okay, brilliant. Thank you, Mariam. So Mariam used the Biopsychosocial. How do you use it if you want to expand on that? How do you operationalize it in your practice? Because for those that are new to us, it sounds arbitrary, abstract, I will say. So for those that use it in their practice, do you want to expand on how you use it, or which one you use and how you use it? Okay. Yes, some of them are not yet back from break. We will continue. So both models, we'll consider them one at a time, and we'll operationalize it, or try to link it on how we sort of use it in our practice. I'm talking about models now generally. Models do help us or enable us in terms of problem solving effectively. They enable us to analyze and monitor exactly what we're doing. They enable us to be successful in devising possibly a treatment strategy. So, but there are other reasoning why we use them. These are the broad categorization of why we use models and how we use it for. So the first one is the biomedical model. Now, the biomedical model, it's an early practice of medicine in the mid 20th century. And the model focuses on, they regard patients as objects, and it ignores the subjective experience of the patient. Now, in the around 1977, researchers or experts, I would say, one of which is Engel, Engel, published an article, and that's what, of course, probably other people have thought about it, but he published an article where he expand on his thoughts that this model, where we focus solely on the biological factors, so that is the biological factors only of disease or pathology, is dehumanizing and it disempowers the patient because it breaks illness into a linear physical component. So think of it like infection, bacteria, or maybe patients have pain, knee pain, muscle tear or ligament tear, or shoulder pain, neurogenic, maybe due to subluxation. So it's too reductionist and it's linear, looks directly link illnesses to the pathology. And it views illness as a result of physical or physiological abnormalities, which it's science, isn't it? And emphasize that diagnosis as well as treatment through medical intervention. And the key characteristics of these models are, it is disease-centered. So its definition of health specifically is the absence of disease. And that's it, the absence of disease. And it's considered reductionist because the linear relationship between the physical components of disease, such as pathogen, genetics, and illness, just directly linked. That's all causation effect is in a singular line. That's it. And it considered treatment focusing on curing the disease, which we might say makes sense, whereby you come, you have the medication, and that's it, disease cured. Or you come, you have the surgery, and that's it. Or other medical procedure. All we are interested in, what is the physical derangement, and then we solved the physical derangement. And I think it might resonate with all of us, because if we are science savvy, we just need to find the pathology, physical derangement, and that's it. And you can say to a certain extent of this model that the strength lies on probably effective care for acute. Imagine a patient lying in the hospital. You just want to stabilize them, make them medically stable, who have unconscious. You want to just provide those medical care, and then that's it. For acute, especially, or inpatient acute setting and infectious diseases, patients are struggling with infection, give them antibiotics and it wipes. That's it. But so this excludes. So you look at it, just the biomedical physical derangement or physiological derangement of our human body. So think of us as humans and our complexities. It excludes what we call the psychological factors as well as the social factors. And in the context of this model, whereby health is the absence of disease, it does not include or consider emotional, behavioral, or environmental influences on individuals' health. And like I said, it's probably, you can say, highly effective for acute condition, provides a clear diagnostics and treatment pathway. And the picture there shows a person. Basically, your option is either you take a medication or you go under the knife, or whatever. As a physio, we just do the muscle strengthening, or you do your heat therapy, or you do your TENS, and that's it. But probably the argument at that time is the limitations that it ignores the other components of health, which is the psychological and social part. So subsequently, people expanded on that conversation, and while this has been successful, but the limitations become more and more obvious in terms of how illness is being perceived and the complexity of illness and the effectiveness of our treatment by narrowly focusing on the biological derangement or trying to heal a person by just looking at the person as he has a pathology or physiological dysfunction. It becomes probably in certain climes less and less effective because there is a complex interplay beyond the physical or biological changes that happens in an individual. And a biochemical alterations, or you will say the biological changes that happens in our body, or when you go to the abnormal lab results, the genetic mutations, the pains, the muscle weakness, the tear, the muscle tear, all those things does not automatically mean the person is ill, really. Yes, it can. It's not alone gives that definition of illness or what affects the person. But the conversation is the health problems arises from multiple causal causal factors. Yes, the biological changes or physiological changes is there, but there are other multiple factors that influence the health of an individual. Apart from the molecular and individual level, there is the social context. For example, a person may have high blood sugar but feel really well, and you will test the glucose and everything, the person really well and function well. And to a certain extent, it start to expand that illness perception depends on context and the impact that it has on the person's life. It's not necessarily merely the absence of disease. The other consideration is that the psychological alterations or psychological factors, which examples are the stress or chronic stress, anxiety, and I think we probably need to appreciate it more in our context. Certainly here, it's a big thing. Or beliefs, maladaptive beliefs that the patients have can manifest as real health problems. Some of the pain syndromes that our patient comes might be from there. In fact, there are functional disorders, like in neurological context or spheres, there is what they called functional neurological disorders. And that does not has to do with merely the biological derangement, because by its definition, the this research is still on new, but they couldn't figure out exactly what sort of the physical or biological derangement. It's down to other multiplicity of factors. So functional disorder and cause illness. And this aligns with probably a bigger model that gives the thinking of a bigger model, which is the biopsychosocial model, which recognizes the mind and body interaction that contributes to health and diseases. The shortcoming of possibly this model is also highlighting that symptoms have meaning beyond the biology. Yes, there might be the presence of biological derangement, such as the MRI scan might show some disc herniation. You will see maybe there is some osteopathic changes in the knee. Maybe the MRI will show some assaults to the brain, or maybe the chest X-ray will show some reduced lung function, but does not explain how the patient experiences the symptoms. And probably does not explain what those symptoms mean in their patient life. We only see the patient in clinic and that's it. What does it mean in their life? How does it affect them? The fear of losing their independence. The attitudes and communication skills that the clinician needs to interpret and respond effectively. Earlier on, we are talking in the morning session for those that are here with us. We talked about the patient-clinician interaction and how responsible we are and the impact. It certainly will impact on our treatment. But so all those things contribute to the meaning of our patient's illness, health, beyond the mere biology that we probably will be focusing on. And if we are to make a decision as clinician, or our clinical reasoning, our judgment should not merely be based on, oh, the range of motion, there is goniometer 20 degrees and that's it. Or the handheld dynamometer, the grip strength is this, that's it. Beyond the data, beyond the quantitative data, beyond the numbers, and the gathering of those information. So when we're trying to do our assessment, and I think that's where the context starts to come in. So think of right from the beginning, when we are trying to do our assessment, gathering and processing that information, it should not be just a technical process where you're going to just draw a line and say the patient comes with pain, I just apply TENS. That's it, expert, treatment, cured. But it requires the empathy, the active listening, and the understanding the patient personal context. As illness is not determined solely by those biological factors, and that is the argument. Yes, the biology is there, but illness is not determined solely by biological factors. There are certainly physiological variables that influence illness, such as stress, coping strategies, social supports, people around, cultural beliefs, all play a major role in who gets sick and why, and there are evidence around it. How much the intensity of treatment, you will see it, and there are research around it. Patient A, patient B, they have the same muscle tear, they have the same stroke, they have the same, but sometimes that psychological factors or psychosocial factors influence how intense the illness becomes, the course of the treatment, how long it lasts, and the recovery of the patient. And this proponents challenges the traditional biomedical view that focuses solely on physical pathology. And for us that are new to those model, and we'll look at the other model, is try to think when you're seeing your patient, the sickness role is not merely because they have biological derangement. And when I talk about biological derangement, I'm talking about the physiological dysfunction. So our normal human body functioning, the abnormality from the functioning that our body expects to have. And people can adopt a sick role in quote or behaving as if they are ill without any sort of measurable. So a patient can come to you and tell you they are ill, but all the numbers, you will run the test and the data, there is no any changes or abnormal biomedical derangement. And it's important as clinician, if moving away from this model, it's important patient clinician interaction, it absolutely influences our outcome. I know we are busy, but how we interact with the patient affects those medical results, affects those brilliant ideas you want to impact on the patient. Either directly, but certainly indirectly. So my question probably at this point is just to ask now whether you know the biomedical model or not, or whether you know the biopsychosocial model or not. Why do you think, or how do you think our interaction with the patient will influence our treatment outcome? How do you think our interaction with the patient will influence our treatment outcome? And I would like to hear people's view or thoughts. How do you think the conversation when you are doing your clinical writing, the clinical, seeing your patients, how do you think will influence your clinical outcome? And I'll hand the mic back to you guys. Anyone wants to share, please come forward. How do you think our sort of clinical interaction influence in your clinics? You guys are experts in your field. Do you think it has an influence? Hello, yes, I can hear you. Carry on.
Yeah. So interaction can influence the outcome of treatment for our patients. Number one, it makes them to, like we talk about them giving consent. So them understanding what you want to do and why you want to do it, it improves their trust in you. Absolutely. And they are ready to comply. So the willingness to go along with the treatment and then participating actively and as expected will most likely improve the outcome. Unlike when the interaction with them is not adequate or it's obscure to them and they don't fully understand, they might not go on well with the treatment sessions.
Excellent. Spot on, Adekoku. Thank you. Absolutely. Yes, carry on, Adefime.
Yes, sir. Good morning, sir.
Morning.
Another reason why I think our communication with them would influence the outcome is that it helps us to know what exactly their desire is at the end of in the process of the treatment, like what they really want. Because most of the time we are looking at the physical outcome, the physical results, but they might have another attachment of how they want to be emotionally effective or socially more involved. So our communication helps us to put together that our own sense of physical outcome and their own desire to be able to function in other areas. And it brings out like a holistic delivery in the long run. Thanks, sir.
Thank you. Anybody wants to add more before we move on? I think these are two brilliant examples. I will start with the first conversation. I think the key word that was mentioned is compliance to treatment. So by the time trust, I think the first speaker mentioned about trust. You establish trust with the patient because you carry them along, and compliance to treatment. The way and the way we clinicians interact with patients, certainly, because it builds that positive relationship. And by compliance or adherence to our treatment, it's most likely for a patient to improved because no matter how effective the evidence, let's say the research evidence, the treatment works. But if the patient do not do it, it will not work. And as a clinician, I feel we owe it a duty to our patients to find ways where we can empower them to make sure that our treatment works by them complying. And that's why our second speaker talks about capturing their desires or perspective. We talked about patient-centered care. Patient-centered care. And patient-centered care is all about capturing their desire and preferences and integrating it into your own clinical practice. And that will motivate the patient to be able to do those treatments outside our clinic. I believe physiotherapy treatment in the cubicle is not the main basis or the focus of rehabilitation. I more or less neuro rehab expert, so I'm geared towards that direction. But in all spheres of physiotherapy, I believe our focus is about how it impacts on the patient day-to-day life and what the patient will continue to do outside our treatment. And we cannot be monitoring the patient in their own activities. We give the ownership to the patients. And how we do that is we build the trust, we factor in something that they are interested in, and then we empower them, which I think we'll probably talk about later on. And that will make them to carry on their treatments beyond our clinic. And believing you me, if it's not something you're thinking about, treatments beyond your four corners of your clinic, beyond one-to-one, beyond 1 hour, 30 minutes that patients think of you, it's something that I will highly encourage because that will transform the outcome of the patient. And this, it might be things that our interaction, it's also the information, but it's about the communication, the empathy, the trust. This, I think they are not optional in assessment, in documentation generally. Apart from the writing of the notes, you have to get the information. They are essential for a successful care. Patients, generally, they are not passive subject. They are not inanimate objects studied under science. Patient responds to how they are treated, they are observed in the clinics. Although sometimes we might be oblivious, or it might be one of the least things we are considering, but they do. They respond to how they are treated, they are observed. And as clinicians, our behavior, yes, we are under stress, but I guess that's why we are professional. Our behavior, our tone, our approach can certainly influence the perception of illness, their willingness to share information. If a patient doesn't share information of us, we will just be speculating. Their psychological states, and which can affect their recovery. And clinicians are influenced by the patient themselves, because once you can see their attitude. Have you ever asked yourself why a patient will be so comfortable with one therapist and not the other? Or have you ever asked yourself why a patient will say, "Oh, I want this. I want to see doing. I want to see XYZ. I want to see okay. I want to see this person." Influenced by, but our attitude also, it's influenced by their narrative, their engagement, which all of this helps form our clinical reasoning. We say we are expert, but the decision, our reasoning that we arrived at those decisions is broader. And take, for example, just to give an example on this last point on the biomedical model, a patient with knee osteoarthritis may have the structural changes such as the narrowing of joint spaces, osteophytic changes, bony growth, outgrowth. But pain severity and the disability will be influenced by the psychological factors. Fear of movement. They wouldn't like to move their legs. And we all know that's not good. Yes, you have this, but you need to move their legs, even if it is load bearing or non-weight bearing. Social factors. Lack of family supports. When they don't feel supported, they just go in, throw whatever you've given to them, and then or maybe there is nobody to motivate them. Now, yes, as physiotherapists, we need to document the impairment. So what is wrong with them in terms of the physiological derangement or biological alterations or biochemical alterations. But also, we need to consider the uncaptured in our notes when we are writing, the activities, the participation, the contextual factors, succinctly. And how we do that is by using what we call the ICF framework, which we'll be talking in our subsequent slide, or the International Classification of Functioning and Disability, that is the WHO, just to give us a framework of understanding of how we think process. Our note taking doesn't change. I'm not saying we are changing the framework. Whether you are new today to this model, the conversation is not about changing the frameworks or model you use in your practice. We still use our SOAP notes or templates you have in your practice. But when you're assessing your patient, when you are writing those information, you need to have like a theoretical, abstract conceptualization of how you arrived at that decision. What is wrong with this patient? So your reasoning, it helps inform your clinical reasoning and your decision making on the treatment of the patient and captures it in your note very clearly such that you avoid the jargons but making very clear and relevant information that whoever is taking those piece of note will understand where you're coming from and where you're heading to and why you use that sort of approach or decision. And now leads us to our treatment, whereby effective care involves, and when you're planning your treatment, you are not only applying TENS to relieve the pain, you are not only doing strength training to increase the strength, but also you are involving education to inform the patient of the process, but also to reassure them functional goals. You are also translating those strength training to functions, not just exercises. What does it mean? I think earlier on one of our speakers just now mentioned about desires of the patient. What does it mean to the patient? And our healthcare, I believe it's not a one-way technical process. It's a dynamic interactions between our patients. It's a dynamic interactions, and both of us influenced each other. And sometimes I personally experience, sometimes if I see a patient, I even feel like they changed me more than I changed them in a way, because when they're sharing their thoughts, feelings, it makes you reflect and think of how you can help, whether they are frustrated, whether they don't want to do the treatment, so all those bigger picture, while there is that biological derangement, you appreciate the bigger picture and how you handle your sort of intervention going forward. And even in a highly biological treatment, even if it's treatment, you feel this has to go, whether you are trying to use the specific biological, you want to address the biological underlying factors, which is good, but it's just appreciating the holistic concept especially for chronic cases. The biomedical model, yes, it works. Straightforward cases, yes, it works. But our patients are becoming more and more complex, certainly in certain demographics, especially the elderly care. So the question is, what is the alternative? If we said the biomedical model hasn't worked for us, and if it's a practice you are using, or maybe if you reflected backwards and you feel like, oh, that's what I've been using, then there is an alternative. What is the alternative? The alternative is, I think this is a break time, but we've already finished the break time. So the alternative is a model that includes the patient subjective experience that we've been talking about, alongside the biomedical data, the physiological derangement. The traditional medicine before now focuses on the objective data. Okay, what is that right in front? The lab result, the imaging, the physical signs. However, the subjective experience, how the patient feels, their pain, their emotions, their beliefs, their social context. I believe in Nigeria, we so much have a lot of very rich, enriching social context and beliefs, but it's how much we appreciate that in the delivery of our health services. It's equally important, because health is not just the biological, but also the social, as well as the psychological parts of it. This probably the acknowledgement of the symptoms, like the pain or fatigue, cannot be fully probably understood by test alone. It requires us to listen to the patient narrative. So the first paradigm shift is a model that includes the patient experience alongside the biomedical data. We are not throwing anything away. The second one is a comprehensive approach. So we said that the biomedical model is quite very simplistic in its approach. It's linear and it's reductionist, where it's a narrowed lens, A to B, and that's it. And the linear model assumes that disease has a singular biological cause. That's what causes disease. But probably the paradigm shift is a more comprehensive and naturalistic approach. We all, as human beings, live in a very complex, dynamic, interesting, interacting world. We are influenced daily by the things that goes around us, the things that goes in our mind, all those things. It's important that it's been appreciated, I would say, in healthcare, and recognize that illness often, okay, I'm not saying that it cannot be purely biomedical, but most at times, as a result of those multiple interactions of those different factors, the biology of it, that's the pathology and genetics that we all learn about, our physiology, pathophysiology, biochemistry, all those things. The psychological part of it, the stress that we are going through in our life, the different coping mechanisms, some people cope better than others, and the support system which we have in abundance in Nigeria. And as a health care system, if I would practice, it's about tapping into that support system on how they can support my patient, the support system. And which is the big topic, the socioeconomic status. And by socioeconomic status, we are talking about how much money or how much household income our patients have. There is no point in giving them an treatment that it's well beyond their reach. We need to appreciate their situation, their educational level, how well informed they are, so where they are living, So all those socioeconomic status, there is no point in you asking them that they have to come to clinic 5 days a week and they have to pay transport. They can't even pay for the treatment, talk less of coming 5 days a week. So all those things, we need to factor it. And that is the essence of what the biopsychosocial model, the new framework that has been developed, which sees health as a dynamic interaction rather than a simplistic causation effect, multiple factors at different layers. So the paradigm shift, the second paradigm shift is a more comprehensive approach to causation rather than a simplistic linear reductionist approach where we see a draw line from point A to point B. This is the illness, this is the cause, and that's it. So problem solved. Let's address the cause and the illness will go. The third thing is a perspective of patient-clinician relationship that accords more power to the patient. Accords more power to the patient. I think we've started talking about it. So earlier in my previous slide, which we said in the traditional model, the patient is a passive recipient of care. And I think, correct me if I'm wrong, I think most of our services, it's where the patient sits and we the clinicians, we are the one in authority and trying to give all those big terms in terms for our patient. But the shift to a modern patient-centered perspective, which we talk about. And that perspective, that patient-centered perspective empowers the patient. There is no point in you telling them to go and do exercise. You can't threaten them. They will go back home and they will just throw those exercise and lie down in the bed and eat their ewedu and bakery. And there is nothing you can do about it. And you come back the next time you will be saying, oh, have you been doing those exercises? Okay. So it's not about you dictating to them how or what they should do, but it's you involving them in the decision-making processes, and that will change what they will do. It's not you, it's you respecting their values, their preferences, and their goals, like the other speaker mentioned about desires. It's about us treating our patients as active participants in their healthcare journey. And that will improve compliance, as was mentioned. It improves adherence. Okay, so that's the last likely impact on patient care. If there is that comprehensive approach to healthcare, comprehensive approach to patient approach, there will be improved in patient adherence. You tell them to do things which you know evidence says it will help them, they will go ahead and do it. It improves patient satisfaction, and you will see those outcomes. When what you want to change, outcomes of care, you will see those outcomes. Because the collaborative nature, when you work with the patient, rather than the paternalistics, whereby in our clinic, where we see our patients like our children, or like think of it like a father will sit down with our parents sometimes, or we as parents in the other way, we just tell our children, oh, do this, do this, do this, do this. No input from these things. We don't care about what they say and everything. That doesn't empower the individual. So, but it's that collaborative nature where we hear them, we understand their views, and we present the evidence, work together with them, and give them the evidence and see what is the way forward. So, in summary, a model that captures subjective experience, look at multiple causation, and put it the center at the patient. And that is what we call the biopsychosocial model. So the biopsychosocial model of care, it's a model that endeavors, the new model, it endeavors to become more contextual and cross-disciplinary. This is used not only on physio, but across healthcare setting. And it works by integrating multiple perspectives, rather than the biological derangement we've been talking about. It considers the medical or the biological aspects of care. It considers the psychological, the thoughts, emotion, the behaviors of the person, such as fear of pain. It considers also the social aspects, the socio-economic status, how well they are faring in their lives, the environment, the cultural context and perspectives. And I think as a professional, that's what it's something that we should be appreciating, providing that contextualized care to patients, tailoring our care to the patient's life situation. And this model, the one I'm presenting on my slides, the whole idea is it's not only about the patient and patient care. Well, of course, it's central, but also it encourages collaborations among the healthcare professionals. Think of the physiotherapist, which is ourselves, the psychologist, the social worker, because what you will capture in this model, or what when you are interacting with this patient, is not that you will solve every single bit of their problems that has been highlighted in this model, in your conversation or documentation, but it's the identification of what are the factors that are likely to influence your treatment outcomes, documenting those, and then making appropriate referrals to other healthcare professionals who will now come in to help in terms of the patient care and carry it on with the journey. Example, when I worked a couple of years back, for probably more than 5 years or so, when I was working in a neuro context. So it's a neuro rehab setting or / community, where a stroke patient, as we all know, for those that are stroke enthusiasts, when somebody had a stroke, while there is the weakness, but there are other things that goes underneath. They lose their coping mechanisms, so their resilience, their ability to, sometimes it affects their emotions. They can become so emotionally vulnerable. And one of the main things we do as clinicians is on the first assessment, we screened for that emotional vulnerability, not emotional, the psychological implications of the psychological impact. And you can use as simple as questionnaires. So usually the practice where I was working at that time has a standard questionnaire that will be used to screen for patients, and depending on the scoring, it determines whether you make a referral to a psychologist, or you just share your thoughts with a psychologist and ask them what do they think, and things like that, and they will suggest, oh yes, I will carry it on, I will come in and support the patient, or maybe you should just monitor it. But also, even without those questionnaire or psychologists, in my day-to-day practice, now recently, there are patients that I will see where you can see that, for example, patients that have had a fall, because they have had history of falls, you telling them to stand on their leg without support, they would absolutely not do that, because they will be holding for their dear life. That doesn't mean they would not stand or they cannot stand. Their muscle strength is good. Their balance is probably okay. But because there is that fear of falling again, the patient would avoid standing on their own, holding to objects, or they will avoid standing at all. And if a physiotherapist or maybe if the healthcare intervention has not taken place early, if a patient refuses to engage those muscles, those physiological systems, they will start to lose. There is a concept of either use it or lose it. So the more patients avoid an activity, even though they are able, for example, deciding to sit rather than stand, deciding to stay in bed, they lose that function. So there is that interaction where the psychological aspect, and that's my arrow on the other bits, can influence this, the biology. So it's bidirectional. While the biology can influence the psychology on its own can influence the biology. So there is that interaction between that psychological and the biological as well. Still on an example that I was given on the neuro context, a patient who had had a stroke. And apart from the screening of the questionnaire we do, those patients now, like I said, Nigeria, we have a very rich culture and we have the family support and everything. But there are also people that are struggling outside our clinic. But here there is the social service, the social support, the social workers, whereby if the person is struggling in whatever shape or form, you can involve, for example, if you want to send them back home after your rehabilitation, let's say they are inpatient rehab and you want to send them back home. It's about what they will continue to use at home is the social context where you can involve the social workers to come and help in the environment settings, or the occupational therapists to come and give that contextual support to modification or adaptation to the patient. So it's looking at the patient as a whole. Yes, I'm treating the physical parts, but I will consider how the physical part affects my treatment and see how I can intervene. The example I've given, the patient who has fallen and avoiding fear of fall, how I will now intervene is I will not push the patient to stand up. Oh, come on, stand up because he can do it. No, I will gradually reassure the patient. Now that is the education reassurance. Reassure the patient by gradually graded exposure to their independence, supporting them, giving them the frame, giving them the supports. And that is what they need. They don't need me to improve their strengths more because they have the strengths. They want me to gradually support them and promote their independence. And from there, they can now sort of continue to build on that. So the biopsychosocial model refers to, so the biological part, which we talked about, which is the biological aspects of health, the disease process, the genetic predisposition, the physical injury, neurological, cardiovascular, or musculoskeletal. And in physiotherapy, it can be herniated discs causing low back pain. The psycho is the thoughts, the emotions, and the behavior of the patient. And that includes the physiological factors that influence the health, the emotional states, anxiety, stress, depression, which are salient in our environment because of the so much high, busy, upbeat. But that doesn't mean they don't exist. The cognitive patterns, the fear avoidance, the belief, the belief system, coping strategies. Example, how patient example is a patient with chronic pain. So we said the biological bit is the chronic pain. The psychological bit or the biological bit is the herniated disc, somebody with disc problem with the backs. And then the psychological part will be a patient with chronic back pain. Of course, they will likely avoid pain. They will avoid movement because they are in pain. They won't like to move. And as clinicians, we see this daily in our practice, whereby the patient will avoid movement due to pain. And it's a natural thing to do. And because they are afraid of worsening the symptoms. But we know avoidance of movement, especially there are safe movement, may delay the recovery of the patient. And to a certain extent, it can complicate the patient's, maybe will have an impact on the biological aspects. But also the last leg or part of the biopsychosocial model is the social part, the socio-economic status, the environment, the cultural. The social part are the social determinants of health. The work-related stress. What sort of stress are they going from their work? This will have effect on your treatment. And that's why in our subjective, which we'll look at later in the afternoon, when we are talking about the SOAP format, we ask them social histories, their family situations, their job demands, the possible support system. Those information, we are not asking them because we just want to hear them without reason, but because it's expected the documentation will inform our decision making subsequently down the line. Both our objective, our clinical findings, as well as the treatment that we'll plan. The economic status will definitely affect the affordability of treatment. And I think probably it's prevalent in the context you guys practice and we practice. Generally, patients' affordability to treatment. But as a clinician, I believe we can also suggest alternative ways. There are cultural beliefs, illnesses. A patient may be struggling, for example, to attend a physiotherapy session due to maybe financial constraints. So back to our examples of the herniated discs. So the herniated discs may cause the back pain. Just to wrap up every conversation, I've been talking about the interaction between the biological, the psychological, and the social. The herniated discs may cause back pain and but it can trigger psychological response like fear of movement, which I think we always see it in the practice. Avoidance behavior. But this may exacerbate the physical dysfunction and the social determinants, such as demanding work conditions, and the social determinant on the other part may further compound the challenges the patient may be facing. Because the social determinants, somebody with herniated discs and he continues to go and do physical work because man got to hustle, they have to go and look for things. It hinders recovery, and that is the socio-economic factor that we have to appreciate in our environment. And these interactions, if you see the arrow, they are bidirectional. So this affects this. So the arrow pointing the psychological affects social, the social affects psychological, the social affects biological, biological affects social, and so on and so forth. Because the psychological distress can influence the biological processes through the mechanism, such as the psychological distress can increase the muscle tension and will delay the healing. Or the social pressures can amplify the strain and the coping mechanism of the patient. And right at the center of the diagram, it succinctly describes the complex interplay of these domains, whereby it can give rise to the complex outcome. So the chronic pain disability, and which at this stage, I think the chronic pain disability, it cannot be explained simply because the patient has a herniated disc. There are other factors that the herniated disc, yes, he has the herniated disc or she has the herniated disc in the beginning, but it has not been properly managed, and those all underlying factors have make it difficult, or we need to sort of take that into consideration when we are considering our treatment. And yeah, Another example. So that's one. So that's the probably I would say the summary of the biopsychosocial model. The interaction between the biological, the social, psychosocial or psychological and the social bits gives a broader, more comprehensive approach to healthcare. Now let's look at this diagram on also another example of how it influences the treatment. And this is a literature in 2015 that was published. Now the diagram clearly illustrates another biopsychosocial model in the context of post-stroke fatigue and depression. So patients who have had stroke. Of course, the stroke, so the biological factors is the red bits. So the one in the red boxes. Now, we know that the process begins with, let's say, some stroke, acute ischemic event or attack, where there is that occlusion of the blood. But once the event happens, it triggers some activation. That's the next layer of the red box of some cerebral inflammatory processes that goes in the brain. And that inflammatory processes increasing the intracranial pressure because of narrowing of the space, and then the nerves are impacted. There will be disturbed neurotransmission. Okay, that's movement of information in the brain, and it can also increase because there is lack of also clearing of the waste products that accumulated in the head. There will be increased neurotoxic potential as well. Now, this is in the specifically looking at the context of fatigue that happens. And most of our patients, one of the characteristic biggest features of stroke is post-stroke is there is fatigue, post-stroke fatigue. It's a big thing in stroke. Now, these biological changes that happen as a result of stroke predisposes, as a normal person without a stroke, maybe they have a big coping mechanism, they can deal with fatigue. And when I'm talking about fatigue, I'm not only talking about physical fatigue, there is also what we call cognitive fatigue. I'm not talking about, oh, I'm tired, which is part of it. You feel exhausted, but also cognitively with stroke patients, there is that cognitive fatigue where they feel exhausted. Even without doing activities, they can feel that cognitive fatigue, even when they are lying down. So those stroke predisposes the patient to fatigue. That doesn't mean they must have it, but it makes them high likelihood of exposure to fatigue. Now, the next bit is these blue boxes, which is the psychosocial or behavioral factors. Sorry, just a minute, drink. Now, the psychological stressors. Example, the social isolation. And I think in our context also it happens despite our rich support system. We just keep the patient in the room and then everybody will go in with their normal life and this patient will just sitting down facing the four walls, or we keep the patients in the ward and then the four walls, and or if they are back home, they are on their own because they are reduced mobility and they can't cater for themselves. So those social isolation it will impact on their psychological well-being. But also the role changes. Maybe they are active, upbeats, they have a job, they have a life, they have a business, but suddenly, bam, this event happened and it takes a big turn. I think all of us will appreciate life events can have a big impact on our lives in one way or the other. So think of it as a normal person, even life event, but think of them as it happens to them as well as their inability to help the situation. So role changes. And then it affects the behavioral factors that we just described, the coping strategies. Now, these blue factors will influence whether the fatigue becomes persistent, or reinforced. The factors contribute to the feedback mechanism. Just after the red, the third red box, where it says fatigue disposed to fatigue, where we acknowledge their fatigue, recognizing their fatigue early, facilitating better coping mechanism, preventing, it will likely prevent the escalation. That's the black arrow that goes all the way up. So if you, yes, they will have a stroke. Yes, they will predispose to fatigue, but how we manage it will make them to come out of it, to break out of the likely cycle loop of fatigue, depression, and going all the way around. Acknowledging it, reassuring them, listening to them, giving them education about their condition will empower them and have a better coping mechanism, and that will influence how much they engage in our therapy. That will influence how much they participate in the rehabilitation, how their mood is, and how cheerful they are. You ask them to come to the treatment, they will come. But if we do not acknowledge that fatigue, oh, you're lazy, you're just being lazy, we're quite dismissive, it may lead, and that is the arrow that goes up, it might reinforce the fatigue because they don't have that coping mechanism trying to figure it out, and might lead to chronic fatigue, not merely fatigue, oh, I'm tired. It might lead to chronic fatigue, and there is no amount of the galong flexion, extension, bending that will probably motivate them. We might have the best brilliant exercises, and document the very brilliant exercise, but they will not do it. And sadly, that's where sometimes we document, oh, the patient is not cooperating, oh, the patient doesn't want to do the exercises, and then we just dismiss the patient. And I mean sadly, because you will see those in notes everywhere in the world, whereby we do not acknowledge the situation of the patient. And you will be so surprised that the same patient, if there another therapist handles it, acknowledge of the fatigue, using that comprehensive biopsychosocial model, the engagement of the patient will be different. And if we don't acknowledge it, it escalates to fatigue, chronic fatigue. From chronic fatigue, our patient will enter depression. And it's not a place where it's a difficult place to be. So the biological changes from stroke interactions, from stroke interact with the psychological response. Fear, frustration, of course, it can be very frustrating. And possibly also the social system or supports that we have within the patients. And the fatigue the patients have, it's not purely because, yes, we talked about the physical and cognitive fatigue. It's not purely because of the stroke itself, but also the complex interplay of those psychology that all play parts in the patient rehabilitation, the patient's mind. And the recommendation is, if we're looking at the biopsychosocial model, is for effective management, it requires us to holistically consider that in our assessment and in our subjective assessment. Just making a direct link to what we do in our assessment is, tell me what has happened, patient paint a picture, taking about the social context, where they live, job occupations, how they are feeling, and all those expressions, they informed us on how we manage things going forward. And a patient like this, now, the biological treatment, yes, there will be anti-inflammatory strategies, or that's on the medical side of it, the medication, but on physio, we do the strengthening, the exercise that we'll do for the patient. But we need to probably, there is that need for that psychosocial support, either counseling, refer them out, or maybe just listening to them, education, reassurance as a physio, education and reassurance in addition to your exercise that you give to them, in addition to your strength training and all those physical component of exercise you will give to them. But also the social intervention, where you include the family members, the family supports, which luckily we have it in abundance in Nigeria. It's about how we include them in our rehabilitation. So in summary, and I just probably go in detail because of the responses I've had earlier about most people, this is their first time of hearing about the model. And certainly today will not be the last. I guess one thing with these things is you probably need to go back to it and see how it applies to you in your practice. While the biomedical model focuses on the biological derangement, the biopsychosocial model gives a holistic view of healthcare, which is what we are promoting in our practice, even without reference to this model or not. Looking at biological psychosocial factors. If you look at the biomedical model, it's linear reductionist, where it looks at treating the derangement only. But the biopsychosocial model feels like treatment should be multifaceted. Our assessment, starting from assessment, our assessment should be multifaceted, where you consider every single bit that contributes to the patient treatment. And that will inform your interventions as well. Probably an example we talked about is a patient with knee osteoarthritis. You just give them exercise only. It's good, it's excellent, but evidence, researched evidence, and as well as a lot of guidelines shows that sometimes we need to go beyond exercise only. We might need to give education to the patient. It's part of the intervention, the coping mechanism. While the biomedical model has its own strength, although the limitation is it ignores the mental and social component. While the biopsychosocial model, it's the pathway we are hoping, and I'm hoping that going forward, people will consider in their practice. It's a bit more complex, and sometimes it can be resource intensive, which is a luxury. For example, you may not have the competency to have some emotional conversation with the patient, or you might not have the professionals, if need be, to refer to your patient, or the professional might not be fully on board, or you might not have the space to think about how you can support the patient, or the time also to consider those bits. But certainly, it is the path to go. And I will come back to my question again. I think thank you for those that have put in their feedback on the chat box. But the question is, now, whether you know about these models before now, I want to hear what model are you, if you know the models before, those two models we just discussed, what models are you using in your practice, and how do you apply this in your practice? Or what sort of components do you think applies to your practice? If today is the first time you are listening to it, or you're hearing about it, I believe as clinicians, we've been using it in one way or the other. So casting your mind back, what do you think you are using predominantly in your practice, even if it's just now from what we discussed? I will probably ask you I will hand the mic back to you to share your thoughts. So my question is, what models are you using in your practice, and just expand on how you think you're applying. based on biomedical, biopsychosocial model of care. Over to you. Love to hear your voices. Love to hear your lovely voices. I believe we have a clinician. Yes, please carry on.
Yeah, obviously, without actual coining maybe biomedical model or biopsychosocial model, but with the training goes on, I've actually been using the biopsychosocial model because in many cases we bring along the psychological aspect of the patient's condition. We bring along even the environment, by setting goals and stuff like that. So it's obvious I've actually been using the biopsychosocial model. It is in my practice.
Thank you so much, sir. But stay with me, please, if you can.
Yes, sir.
How do you think why do you say you've obviously been using it? Can you give us those sort of components you think in your practice you've been applying it? Yeah.
Okay. Not necessarily,
Yeah.
maybe having taught the model before,
Yeah.
but having the background of psychology and
Okay.
some other,
So
factors that affect patient outcome. So we have been using an holistic approach to consider, how to improve the patient's condition, vis-a-vis many other things that might just not be treating the physical condition. So we've been, discovering that and then, attending to it in the course of management of my patients.
okay. What sort of what sort of predominant caseload do you see? Patient caseload. What sort of type of patient do you see?
I'm in the
Okay.
neurology and mental health unit.
Okay, yeah, mental health. So I guess that's why your expertise come in as well. In terms of the neuro, is there a particular neuro condition or you see the broad spectrum of the neuro?
I've received broad spectrum of the neuro. This is Nigeria.
Okay. So let's say I'm the stroke patient that comes to you. How do you so what sort of consideration do you give in my either treatment, or what do you think you tend to pick out in your assessment, in the questions you ask me to get those information of factors that affect me generally?
Okay, after the basic assessment,
Yeah.
And all of that, the diagnosis, then we used to emphasize on setting goals with our patients. And at that point, we might shift away from just the physical function to probably what is affecting the patient. For example, there was a patient who was actually depressed.
Okay.
My junior colleagues were attending to him and they were not able to make progress.
Oh,
So,
excellent example. Not excellent that they can't make progress, but excellent example.
I understand. So then we now ask, we used to review the patient if there is any patient of particular concern.
Okay.
So when they told I have to be involved, then we go there. So we now discover that the problem the patient was having is the relative.
Is what?
Was the relative, the caregiver.
Oh, relative. Okay.
Yeah. Who seemed to be tired and was not ready to stay with him any longer and stuff like that. So you have to address and come in and speak with other relatives, so that they can manage. So eventually what we're able to do is, we made the family to ensure that, that single relative who was the wife, now had some other people, at least two other people who will come maybe on weekly basis to relieve her, so that relative will have time to go home, attend to the children and other things. And maybe after a week or two, it will now be at home. So that's just an example that we go outside just the physical, the functions or the impairments alone.
Stay with me if you may, sir. I think that is an absolutely excellent example. In fact, you seem to have taken it from my slides, basically. The last example I've given about depression and everything. That's excellent. But it seems like is it a government practice or private practice?
It's a government practice.
Okay, that's a good model. So it seems like you have to intervene. So it's more or less you react to it. How do we miss it? So my question is, if we're going to document patient care journey right from the start to finish, is it that that conversation has not happened in terms of what's happening, family situation, who is supporting you in the beginning to the point whereby the patient, if you look at, let me go back to my slide, you can see this bit. Now,
Yes, sir.
as you can see, it is as escalated all the way to the depression before you, of course, sometimes escalation, depending on practice, your junior colleagues will not make reference, will only refer to you complex cases, which is understandable. So it is at this stage that you have to intervene and then start. So do you think we could, have you reflected on how this could possibly have been captured in your practice right in the beginning, or maybe subsequently going forward, your junior colleagues needs to be conversant and familiar with those conversations right early, because the whole idea is capturing it early so that it doesn't impact on patient care. How do you, have you reflected, and how does it apply in your practice?
Ordinarily, they ought to have captured it.
Okay.
But sometimes some of these skills come with practice, and
Yes.
as you develop the skill more with experience, of the probably that's why they mix it. But ordinarily, with their training and then with the method of documentation, they also have captured it and be able to know what is happening.
Okay, you've talked about method, which is what we will talk about later on. So yes, methods of documentation. I think it's important. Those pro formas and methods, it's important, and they help guide we are not robots. We can't remember everything. They sort of help us guide our conversation forward. Excellent. Thank you so much for the contribution.
Thank you.
Anybody, in terms of reflecting on your practice, what do you think? The same question. Thank you for the last speaker. In your practice, what model are you using? And how does it look like in your practice? I believe we're experts in our field. Just taking a bit more, what model are we using and how does it reflect in our practice? One more example, I believe we are doing excellent practice. It's our opportunity to just share our thoughts, our views on those bits and pieces. It doesn't have to be, let's say today is the first bit, just think back of things you're doing. How do you think this affects your practice? One more before we move on. One more person. There's no right or wrong answer. Yeah. Well, I think what I will certainly encourage is for us to think back and see how it captures in. I know we're doing excellent practices, like the last speaker said, just to make sure that going forward, of course, some of those things come with practice. And this could capture it, the essence of biopsychosocial model, everything we've been talking about, really. The medical supports, and that's patient views. The medical support keeps me alive. But it is the psychological and the social supports that enables me to live. Now, apart from the fact, so it's not only in terms of the medical, the psychosocial and the psychosocial influence the outcome of the medical support, but also there are patients with long-term conditions who have to work through those conditions, and those psychological and social supports make a difference in their life. So it highlights all the things we've been talking about. And survival is not enough for well-being. And true living or true health, you will say, it involves living meaningfully. Sometimes we can't cure our patients. Sometimes we can't take away what is happening biologically. But it requires emotional stability. It requires social connection alongside the medical care we are giving them. And as healthcare providers, we must go beyond, well, I would say highly recommend we go beyond the biomedical model of care. It doesn't have to be the name, really. It's the concept. The name is the concept, but I know we are doing it in our health services and embraced a more holistic, patient-centered approach. And I want to ask, also, I want to invite, I really love people interactions. I'm a sort of a one teacher. I'm a teacher of a professor. I love people interactions rather than talking. It's my approach to converse, to learn in teaching, to teaching and learning. So I would probably like also people to share their what is the if you can remember, what is actually the definition of health by the World Health Organization? What does health means? What is the definition of health? Because this also captures it. If anybody wants to share with us, if anybody remembered, what is actually the definition of health, and if you can make real, how does it relate to this code really? If people remember, I think what is actually the definition of health? You can put it in the chat box. Okay, well, not to delay us. If you remembered, the World Health Organization defines health is a state of complete physical, mental, and social well-being. And it is not merely the absence of disease or infirmity. So basically, that's the fulcrum of everything we've been talking about. Now, these are the one model or two model we've considered, the biomedical model, the biopsychosocial model. But the question is, how do we operationalize it? How do we operationalize it or put it into our practice? The WHO or the World Health Organization have what we call the ICF framework, or the International Classification of Functioning, Disability and Health. And this framework that is showing on my screen, on your screen as well, is deeply aligned with everything we've been talking. In fact, the framework is informed by the biopsychosocial model that we've discussed. Because both frameworks, and we are talking about frameworks, views health and disability as multidimensional, influenced by the biological, the psychological, and then the social factors, rather than the purely medical or pathological aspects. And the ICF moves beyond, so the ICF framework moves beyond the biomedical model by considering the functioning and participation in the daily life, not just the disease. So if you look at the diagram, the ICF, there is the health condition right at the top. And then the first box after the bit is the health conditioning, body function and structure. The second one is the activities or activity limitation. And then the third one is the participation. This model, the body structure and function, which is the first box, it is the biological factors or biological derangement or physical derangement. So it's any physical impairment that the patient have. But the model moves beyond just the physical model. It captures the interaction between the body, mind, and environment as also. So it moves beyond the physical impairment, which is the body structure and function. It captures the activities and participation alongside the environmental factors and then the physical factors, which both are considered as contextual factors. And that's the interaction between body, mind, and the environment. If you want to make a link to the model we discussed, is the body structure and function, is the biological factors. The activities and participation is the physiological and psychological and behavioral factors, while the environmental factors are the social determinant or social factors, as well as the personal factors can be categorized as the psychological characteristics. But that is the model. We are moving away with looking at this framework now. So it is a holistic approach. Looking at this, so this model operationalized. So think of the model brings to light or operational, the framework rather brings to light or operationalize the structured way to measure, assess the functioning of our patients, the contextual factors, making it a practical tool for implementing a holistic care. And based on the ICF framework or WHO, disease is considered an umbrella term, which covers both the impairment, which is the first box, the activity limitation, and then what they call the participation restriction. I will be taking turns to discuss about those frameworks in detail. So, like the bit is the health condition, so which can be anything that is wrong with your patient. It can be low back pain. It can be low back pain. It can be okay. So I think probably need to mute. Okay, thank you. It can be low back pain. It can be stroke. It can be COPD. Think of any condition that is the health condition. Think of any condition that is the health condition. And then for this is elderly care or aging. Talking about MW manual wheelchair users. Sorry, I think I need to mute. Where is the mute function? So I think the audio, it's affecting the conversation. Come on. Can you, I think somebody mic is on. I'm trying to figure out. Thank you. think the person. So it is developed and widely accepted, and I believe we've probably come across it in our practice. We've widely come across it across our practice. The impairment level. So when we are talking about impairment level, so think of the body structure and function. Impairment level is the weakness. Impairment level is the pain. Impairment level is the reduced range of motion the patient is having. So it's the biological derangement your patient is having. So the first box is the body structure and function. So the abnormality of the body structure and function, that is the impairment level. The second level is the activity level limitations. What can't they do as a result of that impairment? They cannot walk, unable to walk. They cannot be able to sit to stand. So the second bit is the individual tasks and actions that they cannot be completed as a result of the impairment level. Then the third bit is the participation level restriction. So as a result of their inability to work, they cannot go to the shop, or as a result of both the impairment and activity level, they cannot participate in their day-to-day activities. So think of their quality of life, think of their social engagement. They can't go to Owambe that probably most of us would like to go. They can't go to church, they can't go to mosques. This is something that is affecting them real at participation restriction. All this is happening within the context. There is a context to it, environment at which they function, their home, their community, the barriers they face. If somebody is a wheelchair user, how do they get to your place? Do they have accessibility to wheelchair? So think of the context, environmental context. If they are coming to your clinics, will they be able to access the clinics? If they are using walking stick. And then the personal factors. Young people, how old they are, the skills, are they educated or not, their BMI, their gender, the ethnicity, their marital status, economic status. All these frameworks help us to capture it. But it highlights, for me, it highlights the multiple levels we at physios may need to be thinking and possibly acting at different levels, because our intervention might crisscross at different levels. Our intervention needs to cover all those different levels when we are thinking of it. And I know it's almost 1 o'clock, so we're going to have a break in the next couple of minutes. So the first bit is the impairment level. Having looked at the ICF framework, so we said the impairment level is a problem in the body structure and function. So think of the biological derangement or abnormality that can affect the person's body. My question is over to you. Can you put it on the chat box or share your thoughts? What do you think? Just mention any possible examples of impairment level. Just any possible examples. Any possible example of impairment level. You can put it in the chat box or you can mute yourself. So what are all the possible? So just give an example just to make sure we are fully on board as we go along. Any examples of impairment level which you have frequently seen in your practice? Shoulder subluxation, absolutely yes, thank you. That's example. Yep, keep them coming. Add another one on the chat box. So any possible derangement, any impairment level, that's one. Shoulder subluxation, I think, wow, that's one. Expect a bit more. Any possible impairment that I think your patient might encounter, just put it in the chat box. Yes. Come on, guys, motivate me. You guys have the answers. You guys are the expert. I'm just having a conversation. Post immobilization stiffness. Absolutely, yes, it's an impairment. Post immobilization stiffness, yes. Any impairment level? You guys are expert in your own field. I just want to tap into that wealth of knowledge you guys have. Post immobilization stiffness. That's an example. Okay. Somebody is writing paraplegia. Okay. As an example. So paraplegia is big. Foot drop. Absolutely, yes. That's example. That means we are fully on board. Muscle weakness. Yes. That's example. Thank you. Yes, we're getting somewhere. Yep, brilliant. So keep them coming, but I will probably continue. So that's example of impairment level. Absolutely on board. And my example also, it's the, so these are the example of impairment level. So neurological condition, for example, somebody mentioned about probably paralysis after stroke. The weakness is an impairment level. The shoulder subluxation is an impairment level. The joint deformity or the pain is an impairment level. All those bits, the reduced lung function in CPD, it's all are examples in an impairment level. So if there are impairment level, what are the activity what do we think are the examples of activity limitations? So we said activity limitations are difficulties an individual may have in executing a task or action, and they represent restrictions at the activity level, which is about basically performing basic tasks or complex tasks in their daily life. So unable to do X, Y, Z and everything. So what are examples of activity limitations that you will set? And you can link it to your impairment level, or you cannot, it's all fine. Or you can create a new one. You can either link it to your impairment level or you can create a new one. Yes, so for example, I think people are mentioning good. For shoulder subluxation, it's inability to lift the bucket, lift a bucket of water. Yes, so that's their activity limitations. So yes, joint stiffness, it's examples of impairment. Thanks, Judith. Activity limitations. So what is limiting them in their daily activities? Yep. So joint stiffness, the inability to squat. Yes, exactly. So that's activity limitations. You guys are expert already. Brilliant. For post-immobilization stiffness, yep. Difficulty, yes. So inability to kneel to pray for someone with reduced range of motion. Excellent. But I think we go to, yeah, well, so I think we'll come to that magician. So inability to kneel. So that's activity limitation. And the impairment is reduced range of motion due to post-immobilization. Yes. Now praying, we have started moving. Praying will be participation restriction. And we'll come to that more, Jason. That's a brilliant example. And people are typing in the real chat. There is this real, what do you call it? Real chat function. So post-immobilization, difficulty in grooming. Yeah. Yes. Inability to run. So thank you. Yes. And I think Oladele has already started the conversation. So the question is the participation restriction. If we say trouble bathing, favor, yes. Dressing, eating, yes. So if we say we have impairment, we have activity limitation, the next part of those layers of the ICF framework is the participation restriction. And this here is the problems an individual may experience in involvement in life situations. So think of their life situation. This is about social roles and integration, not just performing the tasks like inability to run, inability to walk. It's about the social roles and life restrictions. What do you think are the examples? And you can link it to your own impairment and activity. But what do you think are the broader examples of participation restriction, or you can create new one? Now, Ola Dele has already given us a brilliant example, and please share your thoughts on the message. Yes, please write. What do you think are the participation restriction for the patient? Now, the example that was put in, it's inability to kneel to pray for someone with reduced knee range of motion due to post-hip immobilization. Now, that is how we write it. Brilliant. But if you're looking at the ICF framework, the reduced knee range of motion is the impairment because it's the body derangement. And what causes it is immobilization. Knee stiffness is also is knee stiffness. The activity limitation is the derangement or body derangement have make the person unable to kneel. Now, because the person is unable to kneel, will not be able to pray. And prayer is important in the person's daily life. So you can imagine how frustrating it will be for the person not to be able to go and pray if it's something that they want to do in their lives. And I believe the prayer involves the kneeling prayer, particularly in our Muslim faithfuls, but also Christians tend to kneel and pray as well on other religions. So is that kneeling showing reverence to in terms of prayer? So that's the example. And I think Umar also, Dr. Umar Abdullahi mentioned about playing with their peer group as the case of injection policy. Okay. Yes. So the child or the adult will not be able to play. That is the participation restriction. Inability to lead a prayer. Yes, Jibril mentioned because That is a participation restriction. And I think this is where it's frustrating for the patient when they cannot do things. We said the example of participation restriction is the work and employment, unable to return to the previous job, the difficulty even finding an employment, or the community life, unable to social event community activities like playing with friends, or continuous schooling, family social roles. Sometimes due to illnesses, we or family, society, we reduced the involvement of those people rather than encourage them. We reduce them. And as a therapist, I think my approach will be to find a way to encourage them in part of that their day-to-day function rather than taking them away from that day-to-day function. Because I think it's quite frustrating, and that's the only thing that makes sense to patient is how they can continue with their daily life. And that is one of our roles as therapists. Be it their parents, they want to continue to be parents, be it in their place of work, be it in their place of worship, they want to continue sports, play, or even just to maintain their independence rather than people doing it for them. How can we encourage them to do it for themselves? That will be the conversation. So brilliant. Thank you so much. In terms of the job after having a stroke. Thank you. So ultimately, I think the conversation is, as physiotherapists or physio, while we aim to improve the person's ability to perform activities that enhances their function, is and then the participation in their day-to-day quality of life, it's important. And as part of our assessment, we will observe the activity limitation and how this may cause participation restriction, as you guys have brilliantly described in the chat function and conversation. But we then, for me, it's the treatment should be functional. My suggestions, functional, participation, life situations, participation restriction. Because if we go back to I think earlier on, somebody mentioned about the desires of the patient, the goals setting for the patient. It's about what will motivate them, what will bring them in. So while we focused on that, but we need to also analyze in terms of the possible impairments, because that has to be addressed as well as linking it to the function. We can then formulate a treatment plan in the context of individual express preferences and how they wish to participate. And we can do that broadly. Okay? And our treatments is not necessarily that we are wrong in our treatments, whereby we said we just want to do exercise for our patient, but it's that we need to consider how we translate that strength training into day-to-day function for the patient. It's not enough for the patient to come to our clinic and just sit down and do exercise and then off they go. Let's figure it out how they can apply it, whatever they do, in their day-to-day practice. And I have an example just here of everything you guys have said. So we said the impairment, we have the activity, and we have the participation restriction. Weakness of the right lower limb, like you guys have rightly described, it could be glute, it could be quadriceps. Unable to walk, the person cannot get to work. And if you are thinking of in terms of exercise terms that you will be doing, is exercise to strengthen the lower limb. That it's looking at interventions at the impairment level, which is brilliant, excellent. but we need to think of translating or linking that to function. And the function is functional limitation or activity limitation that affects the patient. So while we do some strength training like quadriceps bench for the patient to increase their quadriceps, we need to also facilitate walking practice to the patient, be it a parallel bar, be it in our clinic, be it outdoor walking, be it just make it functional. And with the target that hopefully they can be able to return to some participation in their work, community, or society. And either we can modify it by giving them crutches, if possible, or adaptation with wheelchair if walking is not possible, just to enable empowered patients to continue their day-to-day function. And just staying with this example, in the context of neural plasticity, neural changes, there is overwhelming evidence that shows that strength, improving patient strength, doesn't necessarily translate to function. So imagine somebody has lost their ability. So is that processes, that the sequencing, which one comes first, all those complex interplay. So while you are working on the impairment level, it's important we link it to function, especially for certain patient group, neurological patient. How does it relate to function? How do it translate to function? And maybe this is not the context or place to converse, but just to digress a little. In terms of neural plasticity, to facilitate this is the concept of practice that I talk about. One of the principles of practice is there is what we call part practice and there is what we call whole practice. Now, part practice is doing those individual component of those exercises, and whole practice is bringing all those component of exercises together into the activity. So think of when you sit a patient down and you are asking them to do single leg raises or all those exercises, you are doing a part practice for them. How do you relate or how do you progress them either within the same treatment session or subsequent treatment session from part practice to whole practice, whereby you ask them to do something functional in their daily life, be it sit to stand, for example, or be it walking on the corridor, for example, anything that is functional, with the goal that they will be able to engage with a particular life situations. So I want us to break around 1. I'm mindful of time. Just as a stroke example, just also weakness, impairment, we said weakness, activity, limitations, walking, participation restriction, return to work in role and society, and then personal factors, that's the one we discussed, facilitators and barriers of using a wheelchair. So intervention-wise, we may target both impairment and activity to improve the quality of life of the patients and participation in their life roles. And I put this as a class example, but I think I probably won't be able to, I won't do it as a class example. I will do it as a launch example, as a, what do you call it? Break example. So I will give you as a break example. Okay, maybe not this one. I will come back to this. Okay, let's see. Maybe I'll come back to this. I will. Yeah, I will use this. Time move fast, so I've put my break way ahead. So what I want you to do for me is I'm going to share a template. Is anybody from the CSP going to be here? I think we have an anchor. Moderator is here. No? Okay. So I will share a template and I will really like you to do this activity for me. Let's see if I have the template. Somebody mentioning just having difficulty in terms of entering. So the template I will be sharing, I want you to think of, let's see if I have the template first. I think I do. I thought I did. Oh yes, I have it. Oh. So I'm putting it on the platform and I will write a comment on it. I'll put it on the WhatsApp group and you can open it and I will put it here as well. Let's see if I can bring it up. I want you to think of your practice, and I really want you to do this because I think it will be a nice experience for us to all do it. I want you to think of your practice. Allowing me to add. Okay, so I want you to think of your practice and use the template that I've added. Pick a patient from a case, do your research, and then categorize, first of all, categorize the impairment from that patient to a case study, activity limitation and participation restriction. Ignore my, what do you call it? I think the first one is no intervention, is impairment. The second one is activity limitation and third one is participation restriction. So populate that template I've given you into those categories and describe one intervention you will use at the impairment level and explain how you will link it to the activity and participation level. So think of intervention at the impairment level, think of intervention at the activity level, and then think of how it will influence the patient in the participation level. Now that is intervention. So you have the problems or problem list. So the problem list is what we describe them. The treatment, you describe them at different level and how they linked. I would like you also to suggest outcome measures. Now, we've not talked about it because it's almost lunchtime, but so usually outcome measures that we assess patients, we can assess outcome measures at different levels. We'll talk about this more in the afternoon session, but try to have a go at it and see how you guys will do it. Find outcome measures that will assess patients at the impairment level, find outcome measures that will assess patients for that your case at the activity level, and find outcome measures that will assess patient at the participation restriction. So take, for example, you can take a stroke patient and then that is in your case study. So I will recommend you take not arbitrary patients, but patients that you actually have come across. If you are not in clinic practice, you can cast your mind back or formulate a patient. Condition, stroke patient or low back pain, impairment, weakness or pain, activity limitation, unable to sit to stand, unable to walk or unable to bend, participation, you mentioned it. What are the treatment at the impairment, activity level, and how does it influence participation? What is the outcome measures that you will use? So if you are using of weakness, you can use handheld dynamometer as an example. At impairment level, you can use time up and go test as an example. You don't have to include participation, but a participation level, if it's stroke impact scale as an example. And then we can convey back. When we come back, we'll look at that. I know it's your lunch time, so I'm going to give you, so now is 10 minutes to 1. I'm going to give us 30 minutes break extra to do this activity. I would like us to take 30 minutes extra. So instead of coming back by 1 o'clock, I will give you 30 minutes extra to do this activity, and we come back by 1:30. Sorry, no, not 1:30. Is it now is 1 o'clock in Nigeria, right? 2. So 2:30. It's 12 o'clock myself, so 1:30. So 2:30. So instead of coming 2 o'clock, we'll come back by 2:30. Okay. Just to do this activity. Is there any question? Is it clear what is expected? I will try to see if I can, oh no, add that bit. Or maybe let me share my screen. Let me stop sharing this. And let's see if I can bring it up so that people understand what I'm saying. Okay. Is there any question so far from what I'm describing? Any question, or is it clear for us? I will be encouraged if I have a response, either a thumbs up, or you can unmute yourself, thumbs up, or you put a chat just to make sure you understand what I'm saying before we go on break. Oh no, I put the watch video, but that's fine. As just as an example. Oh. Are people clear on what is expected before we go on break? So yeah, this is the screen. I'm sharing my screen. So I think the instruction will be use your case. So I think just find a case that you have used in the clinic, and then try to jot down your responses as an example. So I really want you to use a case study that you have in your clinic rather than using this video. I will probably change the template I've put in on the Blackboard. Where is it? Yeah. So pick a case from your case study, do your research, and share it with us. And then that's the instruction. Okay. Can I have a response, please? If people are clear on what is any thumbs up, any drop in the chat box, just to make sure that people are clear on what is expected. Are people clear? No, nobody has responded. I don't think we're going to go on break without any response, just to make sure people are clear. Are we all clear with?
Sir?
Yes.
Yes, sir. Are we going to be responding in the chat?
No, so I've given you a template. You just use the template and document your findings. When you come, it's just a reflective thought activity. You are more than happy to share your thoughts, but just use the template on your own. Finish it, do it. It's a self activity that you will do it on your own. I didn't know if I answered the question. I did, Fitan.
Partly, sir.
Sorry, partly?
Yes, sir. I don't understand how we're going to be submitting with that template, or we're just going to be discussing verbally.
No. So finish the template. By all means, submit it on the chat. Submit it on the WhatsApp group. So yes, submit it. Okay. But I will pick on those, and then we discuss it a bit broader. So yes, submit the template. But when I come, we will just hear people's thought. Submit the template, please, Adefitan. Sorry. How do you like to be called? I tend to call different names.
Goodness.
Okay, yeah. So yes, submit it on the, I'm going to put an instruction. So complete it and submit it on the WhatsApp group. And then I will pick it up from the WhatsApp group as well. I think it's easier maybe in the WhatsApp group. People's template. So it's easier on the WhatsApp group. So submit it on the WhatsApp group. Just pick a case, submit it on the WhatsApp group, and we can discuss from it. Somebody have raised their hand, maybe have dropped it down. Favor is asking of the template. I have put it on the chat box on the WhatsApp group, but I can add it on the, I will try to put it on here as well. But I said, let's use the WhatsApp group and add the template. Let's see if, okay. Okay, brilliant. So she has seen it. Yes, from your case study, from any case that you've seen, from your hospital, yes. Yes, from your hospital. Pick a case, pick a patient that you've seen on the hospital and complete the template, and we'll talk about it in the afternoon. So yeah, pick a case. I'm going to share my screen again, just so that people are clear on what is expected, because there's no point of us going on a 30 minutes break. So this is the template. I'm sharing my screen again. So what you need to do is first is pick a patient from your case or from your hospital, from your practice, any patient. From your case load or case load. So once you pick your patient, you can research and share your ideas. So what I'm expected is describe, so complete the intervention, complete the impairment for the patient using the template below, and complete the activity limitation as well, and complete the participation restriction as well. Or what do you think will influence the patient? Just the same example we did in class. And then use it to start to write down your rehab ideas here. What do you think intervention that you will use that will link to, that you will do to help the patients, rehab ideas that you will do here. At the impairment and how you link it to activity limitation and participation restriction. And I would say also suggest a standardized outcome measures where possible, any one outcome measures that you will use to assess the patient at impairment, to assess the patient activity limitation, to assess the patient at participation restriction. I will upload this as well, the one that I've just changed, and I will be around from 1 o'clock. If you have any question, you can pop in, and I'm happy to answer the questions based on the activity. But we will come back by 1:30 to sort of continue. We'll come back by 1:30 to sort of continue. Thank you for those that have responded, but hope is clear. It's right 1 o'clock. Sorry, not 1:30. We'll come back by 2:30. Okay. If there is no question, I will say it's break time now. Let's go and have our break. See you on 2:30.